Good afternoon to everyone joining us. We're going to get our program started in just a few moments. If you are able to, we have our chat box enabled to allow you to share your name. If you're joining us from a veteran service organization, if you could please share which organization you're here representing. If you are a veteran, we would love for you to be able to share your branch of service if you're comfortable sharing that in the chat box. And again, we'll get started in just a couple of minutes.
Thanks for joining us today, everyone. My name is Trudy Beeler. I am a community partnership specialist here at Empath Health, and I work with the veterans community. So it's my pleasure to welcome you to our February Veterans Briefing. February, as most of you know, is Heart Health Month, and we're excited to have Joann Correira, who is a nurse manager at VA Bay Pines. She's going to be talking about the VA healthcare system's cardiac programs. And then I'm really excited, after her presentation on cardiac care, she is going to be walking us through the VA Bay Pines website to help veterans, veteran caregivers, spouses navigate through the plethora of resources and programs that the VA healthcare system provides to our veterans. So Joann, welcome. Thank you so much for joining us. If you would like to start your screen share, we can get going into that presentation. And if you'd like to introduce yourself and let us know a little bit about you and what brought you to the VA and how long you've been there.
Sure, thank you. Thank you for having me. As you said, my name is Joann Correira, and I first became a nurse back in the late 90s and went back to school as a nurse practitioner. So actually, I've been a nurse practitioner for over 20 years now. I started initially as a nurse practitioner in the community. I had an office in Tampa where I worked with an internal medicine and cardiology clinic. And then later on, I moved to another clinic in Largo that was both internal medicine and cardiology. So cardiology is very near and dear to my heart. And then I joined the VA in 2008 as a nurse practitioner. And I've worked in our geriatric departments in the CLC, as well as been a provider in our inpatient hospice unit we have here, and was a palliative care consultant in our main hospital and in our clinics for some years before I took the jump as a nurse manager. So I went from expert to novice in the administrative world. So I've been a nurse manager here at the VA in the geriatric service for the past 4 years. So I feel like I have a lot of knowledge and experience in the VA system, both as a provider, as an administrator, in cardiology, and my grandfather, both my grandfathers were World War II veterans. One of my grandfathers is 95 years old, and he lives with our family, and he comes to this VA for his care as well. He didn't start coming until he was 80 years old. So it's never too late to actually access and learn more about the VA and how it can help you, especially in a lot of our services that fall under the geriatric and extended care, or GEC, G-E-C we call it. My mom would be offended that I would put her in the geriatric section, and that's purely just by definition that geriatrics technically is 65 and above. So I apologize for anyone when I talk about geriatrics and the age when it comes to some of these programs. So what I'd like to do is the first part of the program, Trudy had asked me to talk a little bit about cardiovascular disease, especially since this month is American Heart Awareness Month. So I went down memory lane a little bit and to find out, how did American Heart Awareness Month even start? So let's see if, okay, so this was a little history that I didn't even realize, and so I thought I'd share it with you. Hopefully you guys can see the print okay. So actually this first came about recognizing nationally heart disease as a nation back in 1963. So Congress apparently jointly requested a resolution for an annual proclamation. I just had to put the jointly in all caps just in our current political system. So I found that refreshing to see that. So Congress asked the president to make a proclamation. And so President Lyndon B. Johnson was the one in that position, and it was called Proclamation 3566. And he signed that proclamation on December 1963, 10 days after Congress asked him to. And he did actually have a speech where he spoke about it, but I'm not going to bore you with that. But I did look that up myself. So if you're a history nut, you can read about that. The next pivotal thing that happened after that, so that was huge. So that was the first time it was nationally addressed that there was a cardiovascular disease problem in our country. And then following that, in January 11th to be exact, the Surgeon General at the time, Dr. Luther Terry, he published the first federal report that actually showed the link between smoking and the negative impact of it had to heart disease and lung cancer. So I don't know when tobacco companies, I didn't go that far into it. I don't know when they started shifting, but this is the first time the federal government actually published something documenting the link between the two. And then that February, the month afterwards, was when the first American Heart Awareness Month was celebrated. The American Heart Association has been the biggest proponent, and they were probably right there in the middle, but I didn't want to go into too much depth. So you got the basics of it. And then the CDC and the American Heart Association, they kind of worked hand in hand, I think, in the beginning in all of this. So why is having awareness of cardiovascular disease even important? So just a few facts. It's still, to this day, remember that was 1964, to this day, it is still the #1 cause of death in the United States for both men and women. February has also been more recognized for more heart awareness for women. And so sometimes it's linked to specifically women, and there's even a Wear Red for Women Day in February. And you may see the little red dresses that some people may wear on the specific day. I think was the February 4th. But you may see people who are near and dear to heart disease wearing it for all of the month. And I think the main focus recently on women is because it was always focused on men for all this time. And so then realizing and recognizing how women also have these same health problems and how women present differently. Our risk factors may be different, and how we actually show or it's diagnosed or found can be different. So now I'm bringing everyone together, men and women, but also separating so that you all know in the audience, since I can't see you, that there's a difference in it as well. So unfortunately, still 1 in every 4 deaths in the United States is related to some form of cardiovascular disease. And I'll go into that in a little bit, because cardiovascular disease is a very broad name and topic. And I bet you if you even went to different providers and asked them what it meant to them or what fell under it, you would probably be getting different answers from everyone. So don't feel bad or think you're just not sure, because everyone kind of uses a lot of phrases interchangeably. Heart disease, cardiovascular heart disease, what's what. So I chose one way to break it down. It doesn't have to be just this way. You may hear it differently, but that's okay, because what it boils down to is our whole body is filled with blood vessels. I think everyone can agree on that. And all blood vessels lead to the heart, and they also come off the heart and supply blood and oxygen to all of our organs and skin throughout our body. So if you think of it that way, anything that's related to a blood vessel that needs blood and oxygen kind of falls under this. So with 1 in 4 deaths, that's 17.3 million deaths per year. And it's not a matter of just death. It's the leading cause of illness and disability. So, you know, there's a car accident and people are like, oh, did anyone die? And you're like, oh, thank God no one died. But no one ever knows or talks about, well, there may have been severe injuries and those people's lives have been dramatically changed for the rest of their life. They can't work anymore, or they need assistive devices, or they can't live alone anymore. And that's the same thing that I think of with cardiovascular disease. You know, it's not a matter of did you live or die, but how did you live? Your quality of life, and all of that matters. And that's why we want to talk about the entire thing. And that, I see Trudy nodding her head. I don't know if you can see Trudy, but you know, that just comes at the heart of palliative medicine and talking about quality of life. You know, it's how you live, not how you die. And so all of this all wraps around that concept. That is really my passion. So, like I said, I was going to break it down into 4 main types of cardiovascular disease, and this may or may not help when you break it down. So, coronary artery disease, or CAD, you probably have heard that. Sometimes that can be used, coronary artery disease can be interchanged with cardiovascular disease. That really isn't the same, but it falls under it, because coronary artery disease only focuses on the blood vessels in your heart that actually supply blood and oxygen to your heart. So your heart pumps blood out through its blood vessels, but it's an organ too. So it has its own arteries that supply it. So that's coronary artery disease. So it's essentially, and I'll tell you later, it's the blockage of those arteries that are supplying the blood to the heart itself. So another type of cardiovascular disease that falls under the umbrella is strokes, or TIAs, or transient ischemic attacks. this is one that I think a lot of people would not even think about it being related to cardiovascular disease. And that's why I wanted to point out to you, just think of your entire body and every place blood vessels travel. And your brain is huge as far as the need for blood and oxygen. So if you have a blockage in your blood vessels to your brain, that's what can cause a stroke, which leads to permanent damage or loss of tissue in your brain, or a TIA, where that's some reversible injury. Injury versus tissue death are two different things. So the third main type is called peripheral arterial disease. So by the name peripheral, you can imagine it's related to blood vessels that supply our peripheral limbs, primarily our legs. Our arms do not have the same large blood vessels that our legs need, since we walk and have very large muscles in our legs to help keep us mobile. So peripheral artery disease is blockage of blood vessels in primarily your legs. So you can have a lot of pain that can be very debilitating if you have blockages. So pain in your legs when you walk is the same as if you have pain in your heart, or chest pain, or angina type pain. They're all caused by blockage or narrowing of the blood vessels. So in peripheral arterial disease, you know, some of the interventions are the same thing. You know, they do put stents in, they do angioplasty where they put a catheter in and they open up the blood vessels. They do bypasses. You've probably heard of bypass surgery for the heart. Well, there's bypass surgery for your legs too, where you're literally connecting an artery to somewhere else to give a new blood supply. The fourth main one is aortic disease. Our aorta is our largest blood vessel in our body, and it's in our abdomen and comes up to our heart. Our heart, everything's connected. So it comes up to our heart, but it affects our lungs and all the blood vessels in the rest of our body. So if you have significant blockage or disease in that big blood vessel, then that can affect a lot of other areas. Aortic aneurysms are probably one of the number one common types of things that can develop in that large artery. And we'll talk a little bit about that. Any questions right now about the four main types or the basics that we've talked about? I understand that typing questions into the chat is encouraged, and I do have the chat box up, and I do have support here by Trudy or Melissa if any of you do type it in. So I certainly welcome it, encourage it. Okay, so now we're going to go through each one just a little bit. I'm making this kind of short and sweet because I could talk about this for days and days. Coronary artery disease. So I want you to think of the heart as a pump, an electrical system. Just kind of break it down. Sometimes in my practice, and I was seeing people for heart disease, you know, really like finding out what kind of work you do. What do you understand? How can I relate to you so that we're not talking about all these high-tech terms that you don't know? Because the heart is, like I said, literally it's a pump, and pumps have pipes. And electrical system, you know, you may not be an electrician, but you still have a general idea that your air conditioner or your microwave or stove are not gonna work if you're not getting the electricity to it. So simplifying it in that way, and then it helps you, or it helps me, and people said it helps them to kind of visualize or picture what's doing what. That it's not as complicated as you think. And I want to say cardiology is probably one of the cleanest and most straightforward organ systems we have. Cardiologists would probably disagree, but I think it is. So if you have all the vessels open, the the blood pumps through well. So your heart has to have all the vessels open to be able to work and pump the blood to it and through it. The electrical system, like I said, is also to keep the pumping of the heart coordinated. Because if you think of your heart as a pump, and you've seen pictures and everything else, it's squeezing. But it's only squeezing in that rhythm because of the electrical components. There's nodes in your heart that say, okay, atria, squeeze now. Okay, ventricles, squeeze now. So that it's very rhythmic. If your electrical system loses its rhythm or gets out of sorts, then it just kind of quivers, and that's how you get arrhythmias. Arrhythmias you may have heard of, atrial fibrillation. It's a very common arrhythmia. And atrial fibrillation is where, I'll say, I wish I had a heart diagram. This would have been great. The top part of the heart is where you can get the atrial fibrillation problems. The bottom is where you can get, you've heard of ventricular tachycardia, ventricular fibrillation. I'm just throwing out words just because you've probably heard them at one time or another. We're not going to go that deep into it. My point is you need to have your electrical system working well for it to pump well. Okay, so now that I've broken down the heart as a pump and electrical system, what are some things that can go wrong? Some of the big things are you could have a heart attack. What is a heart attack? Heart attack is when blood supply is cut off to the heart for too long, and it can cause heart tissue to die. And so the earlier blood supply is returned, the less tissue that dies. So if you are having chest pain or pressure, then time matters. If you, and I know no one wants to call 911, people don't want to go to the emergency room. They think, oh, I can drive myself, or oh, it's going to go away. The reason why there's such strong campaigns about calling and going and seeking help fast is because the longer you wait, the more potential damage you're causing to your heart. And it's irreversible damage. So if your heart tissue dies and enough of it dies, is affected your heart as a pump, because there's parts that need that blood supply, and then it will also affect your heart as an electrical system. So if you've had a heart attack, you may also develop arrhythmias. It's very common to develop atrial fibrillation after you've had a heart attack, if the damage in the heart was in that area. Heart failure. Heart failure is what that means, congestive heart failure or heart failure. That is related to the heart as a pump. So thinking back to the pump, how well does it squeeze? And if it's not squeezing as well, it's not getting all that necessary blood and oxygen to the rest of the body. Lots of things can cause heart failure. Heart failure does not mean failure per se. It means it's not working as well. Ejection fraction, if any of you have heard that. Ejection fraction gives us a number. It kind of quantifies what degree of heart failure someone has. So a normal squeeze of a heart, you think, all right, if I'm squeezing normal and my heart's functioning normally, it should be 100%, but it's not. Actually, 55 to 60% is considered a normal ejection fraction, or normal, that's the percent of squeeze of your heart for normal healthy hearts. So if your ejection fraction drops to 40% or 30% because of damage from a heart attack, then that's less squeeze. So instead of like squeeze tight, it's like a moderate squeeze that pushes blood and oxygen through. It doesn't mean the heart has failed. The heart is still working. That name is a terrible name if you ask me. Angina you hear angina a lot, and that can be like a chronic thing, chronic angina versus an acute angina. Angina is just a fancy name for when you're having pain due to lack of blood and oxygen to a certain artery. And having angina doesn't necessarily mean you're having a heart attack, but the only way you know is if you go in and seek medical care. So even if you are someone that's been diagnosed with cardiovascular disease and you think you're having angina or you're having chest pain, you still need to go in and seek treatment because you need to have it worked up to know whether this is a chronic thing to expect and manage the symptoms, or this is something that requires more urgent intervention. Okay. The next big category, the stroke and TIA, like I said, it's when blood is cut off to the brain. That's either reversible or permanent. So if you hear someone had a TIA or you've had a TIA yourself, it can be confusing because they do CAT scans or MRI of your brain and they don't see anything wrong. There's no signs of blockage or tissue death, which is what you would see if it was a stroke. So a TIA is kind of like a warning sign. It's a red flag that you had some temporary blockage of blood flow, and it's diagnosed based on your symptoms and when they started, when they stopped, and doing CAT scans and MRIs to making sure it wasn't actually a stroke. And a stroke, they sometimes are calling a brain attack because there was a big campaign because people weren't taking strokes as seriously or calling for help or seeking help through 911 or the ER as they were for heart attacks. So protecting your tissue in your brain is just as important as the heart and is also affected by time. The longer you wait, the more damage that can be done. And so again, if you think you're having a stroke, and some of those common symptoms are, you know, change in like a facial droop or inability to speak well, you know, loss of function or feeling in only parts of your body, you need to call 911 so you can make sure it's not a stroke, so they can, or even if it is, so they can intervene earlier. My own mother, who is a nurse, who has a daughter who's a nurse practitioner, she had a TIA and never even told me because she felt like, oh, it went away in 30 minutes. And so that was even hard on a personal level to say, but you knew it was potentially a stroke, but because it resolved so quickly, you didn't call for help, you didn't tell anyone. So it was really a eye-opener for me as far as open communication with my own mother about recognizing it and then seeking follow-up testing to see how you could reduce your risk. I'm watching the time, we're at the halfway mark. So we'll get back to stroke in a little bit here about what do you do to help it. So the fourth one is peripheral arterial disease, which I kind of already spoke about as far as it being a reduction in blood supply to peripheral areas of your body. Legs are most common. There's other areas too, but that's the biggie that I would want you to take away. Okay, aortic disease, we already talked about that as well. I don't think I want to touch that anymore. Aortic aneurysm is the most common type of event that can happen, but smaller vessels that branch off can be included in that category. All right, so nitty gritty, you all have probably heard of some risk factors and may or may not know or have heard about how you can control some and you can't control others. The ones you can't control, I listed first. You can't control your age. However, the risk goes up as we all get older for everybody. The average risk increase has been around forever. At about 50 years old, your risk starts to increase. But I don't like having a cutoff point because what we do in our 20s and 30s and 40s all impacts where we're at in our 50s, 60s, 70s, 80s, 90s. So I don't like the idea of thinking, oh, well, my risk doesn't go up until I'm 50 or after. Oh, wait, I'm female. Oh, it's even farther. I'm just going to hold off on doing all these things to reduce my risk. So I don't focus on the age so much, other than to say the risk goes up as you get older. The earlier you try to reduce your risk factors, the better. Okay, family history. Family history, you can't help that either. The risk factor with family history is if you've had a family member that had early cardiovascular events, meaning they were in there, this is where age does matter. You know, in their 30s or their 40s, they did actually have a stroke, a heart attack, or they had heart failure, or they developed arrhythmias, or any of those other big categories I told you about. If they've had any of those in their 20s, 30s, 40s, then that is an extra risk factor for you. So if you're male, if you've had a father or a brother who has had any of those events before the age of 55, I say 30s, 40s, 50s, but up to 55, that's your risk factor. For women, if you have your mother or your sister, so first degree relatives, not aunts, uncles, grandparents, that's a little spread thin. But any immediate first degree relatives, female, if any of them have any of those cardiovascular diseases that I brought up, that puts you at higher risk if they had them or were diagnosed with them before they were 65. So men 55 and younger in your family puts you at higher risk. Women 65 and younger in your family. So as I think I've said before, I'm going to repeat it. Women do tend to develop heart disease later than men, which is why there's the difference. But it's not an absolute. It could be out of the blue, someone had it earlier because of their other risk factors that we're going to go into next. Well, let me touch quickly on ethnicity. Most ethnicities here in the United States, cardiovascular disease is #1 cause of death for the groups. The only two that really, or three that stand out in the research I checked recently, Asian Americans, Pacific Islanders, and Hispanics, it is #2, second to cancer. So for Asian Americans, Pacific Islanders, and Hispanics, the #1 cause of death for those ethnic groups is cancer, with cardiovascular disease being #2. So you don't want either one of those, but it's the only small tweak. So African Americans, American Indians, Caucasians, Alaskan Natives, it's #1. So like I said, now let's talk about the other risk factors that you do have control over, smoking or not smoking. You know, it's just a choice. And part of my belief in palliative medicine is informed decision-making. You know, if you know all the risk factors to smoking, if you were coming to see me as a patient, I'm not going to lecture you on it. I'm going to tell you all the reasons why it's best to stop smoking, and I'm going to give you all the resources and encouragement to help you stop smoking. But if you say, I don't care what you say, this is what I'm going to do, then that's okay. But that was my personal practice to do that, because what I don't want to happen, and I hope what's not happening to you, is that others are telling you, you know, that you avoid going to see healthcare providers because you don't want to be lectured. So maybe if any of that's happening, you can have a conversation with them, you know, this is the way it's going to be. But always, I'm going to try to encourage you not to smoke and help you do it. It's one thing just to say, stop smoking, but it's to really help you through it. Because in my practice of over 20 years as a nurse practitioner, quitting smoking for people seemed far harder than them quitting any other type of drugs or alcohol. because it's just so addictive. And I don't know, that seems shocking to me even now that I've experienced it, but you know, people can quit a lot of other things easier than this. Okay, other risk factors, hypertension, which is high blood pressure, huge, huge, huge risk factor. If there's one thing I could encourage you to do is work with your providers on getting your blood pressure under good control. And that's through open communication. You know, them giving you, this is what I'm giving you, this is why, here's your target numbers that I want you at, because everyone's different on where your target blood pressure should be. And only your provider, it's very individualized, only they can tell you. So if someone asks me, hey, what's a good blood pressure? It's like a loaded question for me. I mean, I can tell you, I can spew off, well, less than 120/70 is like the ideal one, but it actually varies. So hypertension is a risk factor, high cholesterol, those are two biggies. Inactivity, which is why they're always promoting exercise. Poor sleep. This is something that working in cardiology over all those years, I never ever focused on, and I think it's only really emerging more in I don't know how many years on how much poor sleep can impact your overall health, especially even just your cardiovascular health. It's not like I had a bad night of sleep last night. It's a cumulative thing. If you've been a poor sleeper for a long period of time, then I would encourage you to really start exploring how you can improve your sleep. Not just, you know, take a melatonin, take a sleeping pill. It's more than that. It's really adjusting some patterns. It can help. And attached to that is sleep apnea. Untreated sleep apnea increases your risk of cardiovascular disease and overall mortality or death. If you've been told you have sleep apnea, you think you have sleep apnea, then you really need to go ask to be tested for it. They have such easy home tests for sleep apnea now. You don't have to spend the night in a lab. It's much, much easier and can really improve your overall quality of life. So that's my big message on sleep apnea, how much it's impacted and how few people actually go and get it treated once they know they have it, because they don't think it's a huge impact. The other big chronic disease is diabetes. Diabetes and cardiovascular disease go hand in hand. Managing your diabetes and keeping your sugar under control is huge. And hypertension, high cholesterol, and diabetes all affect managing numbers or blood levels. So the only way you know that they're under control is through checking your blood pressure and checking labs or checking your sugar. So there is a part for you as far as going to get these tests and understanding what those results mean and how you can manage them through medicines or other things, not just medicines. There's things you can do. I want to encourage you to not be the passive patient. I mean, medicine these days has really evolved into, this is a collaboration. You know, your doctor, your nurse practitioner, your PA, whoever's in front of you, they can be telling you all these things and checking their box, but unless you're engaged with them and you take some ownership on what can I do to improve myself, will you be successful? Because they can throw pills at you and they can tell you what to do, but until you engage in it and feel like you're a part of it, it's not going to be successful for you. So that's my urge, my challenge for you is to really, and if you have someone that's not willing to have that open communication back and forth with you, perhaps you need to find someone else, because they are out there to really talk to you about it and partner with you. I know it used to be very, oh, the doctor told you this and you just do what they have to say. And that's just really not the way it should have been or how it should be now. So all of these things really affect your blood vessels. and your blood vessels and damage to your blood vessels and plaque buildup are what cause everything I just talked about. Literally, high blood pressure, high cholesterol, high sugar. Those three are the three things that cause your blood vessels to be damaged, meaning get rough. The lining gets rough, or they get narrowed, or plaque blocks them completely. I'm trying to avoid getting into the weeds on it. Hopefully I'm being clear. So, like I said, what can you do to reduce your risk factors? Working with the health professionals that you're seeing to keep things under control. That partnership, and I'm going to call it a partnership, and I encourage you to ask for it to be a partnership, is the best thing you can do. Wanting to get your cholesterol checked. Hey, yeah, your cholesterol numbers could be high. What can you do to reduce it? And let them know what your values and your beliefs are. You know, if you say, I don't want to just pop a pill, okay, well, here's all the things that you can do without taking medicine, but here's the pros and cons to just doing that. You want to hear both sides of what you can do and how far each thing can go. My mom, I'll use my mom again because she's not here and we'll have no idea I talked about her. She has been avoiding managing her blood pressure for some time. She's like, oh, well, you know, it's 130s or 140s. It's okay every time I check it, and did not want to take any blood pressure medicine. But the longer you put off, when that's borderline, we'll call it for her sake, the higher risk overall for damage. I used to tell my patients, you know, you have to have set limits. Okay, 3 months, 6 months, whatever's going on, we're gonna agree to this. And if all of your efforts and you're truly doing them, they help and your blood pressure is in a good range, that's awesome. I don't want to have to give you a pill either. But in that 3 to 6 months, if it's not, I'm not going to keep negotiating with you because I'm harming you by not letting you know, no, now you really need this because you're harming yourself. So just keep that in mind. That goes for blood pressure. And my mom's on blood pressure medicine now, and she wasn't before. And remember, I said she had a TIA. So now I would hate to have you have the TIA, have the stroke, and have the heart attack to say, okay, fine, I'll take the blood pressure medicine. Maybe she would have had that if she had been more open to try things while it was still in her mind, just borderline, and it was okay. Okay, so keeping the cholesterol, increasing activity, you know, walking 30 minutes a day, they tell you to do this or they tell you to do that. I just want you to move more than you have been. That's all I'm asking you right now, because you know, I've told you, and others have told you, and it's everywhere, that being sedentary increases your risk. So managing your diabetes and your sugars are super important. Stopping smoking, reducing alcohol. I'm not going to dwell on this. High levels of alcohol intake increase blood pressure, increase cholesterol, so they aren't directly linked. You know, you drink alcohol, it causes heart disease. It's not directly linked like smoking is. But if you drink in excess, it causes damage to your blood vessels. It raises your sugars and leads you to potentially being at risk for diabetes. And depending on what you drink, it can also increase certain levels of your cholesterol, like triglycerides or other things. Treat sleep apnea. And then the routine health visits. They really do matter, because when you show up in the ER with a blood pressure of 200 over 100 and chest pain, and you're having a heart attack or stroke, you're already behind the game. So going routinely, you may be at risk or still showing up in an ER at some point. That's why they're there. But if we can reduce your risk, the goal is to keep you out of the ER, keep you out of the hospital, keep you healthier, keep you doing what you want to do. So even if you're like, oh, I don't want to make a visit, I'm tired of going to see doctors, I'm tired of taking medicines, the whole point is to, like I said, keep you doing those other things you want to do. Let's keep you out of the hospital. keep you as healthy as you can. Okay, how do you know if you're doing all you can? This is where most of you, I'm assuming the audiences are veterans, is my understanding. So if you're assigned a PAC provider or PAC team, or you're getting care in the community, I don't care where you're getting it. One, I hope you're seeking for routine screening. And two, I hope that you're talking to them about what your risk factors are. Ask them what the specific target number should be for you. Not in general, not according to studies, but for you, for your family history, for your personal health. This is where the bringing the questions to your providers really matters to get engaged. And you know, if you're not getting anywhere and they're giving you medicines, or you're doing what you think you can, and you keep going into the provider and your blood pressure isn't well controlled, ask, what else can I do? Maybe it's time for you to see the cardiologist. If your blood pressure is not well controlled, or you're having other symptoms that may suggest you're developing cardiovascular disease. Ask them if there's routine screening that you should be doing that you haven't done. And that's like carotid ultrasounds. That's a screening that helps to help you see where you're at for risk of stroke. Other routine screening, like I said, is checking your blood pressure, checking your weight, checking your cholesterol and your sugars. Abdominal ultrasounds, that's another screening test to check for that your aorta is healthy and not getting narrowed. There's another one that's not used as much to check on the blood vessels in your legs. It's called ankle brachial index, where they actually can check the pressures in your legs. It's very simple and can be done in the office. They can also do ultrasounds of it too, but that doesn't check the pressure so much as for actual blood clots. Taking medicines as prescribed, and if they prescribe you something and you decide to take it for whatever reason, when you go back and see them, please tell them. You're not in trouble. They're not your principal. They're not your teacher. They're not your parent. It's okay. Just let them know, because if you just say, oh, yep, I'm taking everything, they're going to assume whatever numbers they see or lab results they see are based on you taking that medicine. And then they may say, oh, well, you're not in good control. We're going to give you a second pill. When really, if you'd just taken that first pill, that's all you would need. So providers don't want to cause you harm or give you extra things. So just letting them know you're not taking it, and just tell them why. And what I usually do would ask, in a very non-threatening way for people, are you taking it? Are you taking it every other day? How are you taking it? Are you, I'd say, sometimes people can't afford it. Is this an issue for you? Where it can be explored. So I hope that you're someplace that you can feel comfortable, that you can say, listen, I'm not taking it, and this is why. Is there another thing that we can do? What else can we do? There may be a point, though, if your blood pressure or your cholesterol is not controlled, they can say, in addition to doing all these things, nothing is going to help unless you take the medicine as well, if that makes sense. And Diana Mangson, I know I saw your question earlier. Let me just check really quick.
So we answered one of her questions,
Okay.
But there was a question about is it possible for an ejection fraction to improve after a heart attack that leaves a person with an ejection fraction of 35%. So can it improve?
It depends on, can it? Yes. It depends on what caused it to be reduced in the first place. One really good example is viruses can affect the heart or attack the heart and cause severe damage. And then the resolution of the virus and the heart can kind of do some repairing. There is a certain level of repairing the heart can do. And we actually have a lot of medications that have been proven in very long studies. These studies are not just random, I talked to my friend, I talked to my mother, anecdotal things. They really show whether something's going to work or not. And so that's another question. There are medicines specifically that we know can improve ejection fractions. So can it improve? Absolutely. So this one was heart attack last weekend, 35% ejection fraction. Smoker, parents died young, mother on car accident of drug overdose. So the main reason he had the heart failure was related to his heart attack. And so really it is a matter of taking, unfortunately for him, medicines is what's going to make that improve for this particular guy based on the very limited. So sometimes there's things where nothing can change it. And how do you know? You know, after a heart attack, there's certain types of things that you should be taking that we know reduce the risk of further heart attacks. Not stop it, reduce it. So you start those types of medicines, and then you check an ultrasound or an echo again, either 6 months later or a year later. So it's trending the numbers. So if you're not seeing any change in the trend at like a year's mark, then most likely it's not going to change or improve. And that's where it's at. Once you have a decreased ejection fraction, it's really important that you do routine screening of the echoes yearly or every few years, depending on the personal recommendations, to monitor for it actually decreasing so that your management could change to help reduce that risk. So short answer is yes, it can help, but it depends on what the cause is and making sure you're on the right management and taking it and knowing what's helping what. Okay, and the reason I paused for that is because that was my segment on cardiovascular disease. I covered a lot and I covered it quickly, so hopefully I didn't confuse anyone. Bay Pines VA has a cardiology service that has for inpatient. If you're in the hospital, they see you inpatient, they see you outpatient. They have a congestive heart failure team, CHF team that rounds if you were in the hospital. And if you're being followed for CHF or heart failure, as I hate to call it, they have a clinic specifically for management and monitoring of this, and it's actually called the Heart Success Clinic. It used to be the Heart Failure Clinic, and obviously other people hated the name failure and named it the Success Clinic, renamed it as the Success Clinic, because it's okay, so for whatever reason you develop this, let's try to help keep you your health as manageable as possible for you, again, for that quality of life and doing what you want to do. So it's a type of clinic that does a lot of frequent close monitoring and extra education to help keep you out of the hospital. Like I said, we want you out of the hospital. They also have monthly classes for education for people newly diagnosed. And my goal was, and I think I've now run out of time, and if you guys are interested, we can maybe in the future, if there's interest in your group, and it's something that Empath Health is interested in, I would really like to spend that time, or somebody to spend that time to do what I wanted to do, and that was to actually get onto the VA website and navigate it through it with you to be able to show you where you can look up these resources. Where do I find the number for the cardiology clinic? Where do I go to see more about the Heart Success Clinic or the Geriatric and Extended Care Service? The Geriatric and Extended Care Service that I work for has so many services that you could be eligible for. We have our CLC, which is the Community Living Center, where we have 103 inpatient beds available for short-term rehab, care of complex wounds if you need long-term antibiotics, meaning like 6 weeks of antibiotics. So that is an option. There are all of these clinics I'm going to mention really briefly here, all have different types of criteria. And I could show you how to find some of the criteria and resources on another time. Or, like I said, you can have someone show you or start scrolling through yourself. We do have an inpatient hospice unit. It's an 8-bed unit that we have here for all veterans. As on an outpatient setting, we have an outpatient palliative care clinic. As you know, I'm speaking for the VA. I know Empath has a lot of these too. So having choices is just good to know. So across the board, you know what your interests are and where you might be able to find services. We have Homemaker home health services. For those who have a certain level of service connection, we have VA approved contracts for community nursing home care with VA oversight. We have telehealth programs where it's a way that you can manage blood pressure, blood sugars, weights, all kinds of things through connections through your phone systems and people who can monitor those numbers and give you a call. I think Empath has that too. A lot of things we have Empath has as well. We have a caregiver support program, which is a really big program that started in the last year. That's really helping keep a lot of people at home where they want to be and not have to, look at assisted living facilities or nursing homes. The goal of the VA really is to try to keep you at home where you want to be for as long as you can with whatever services we have that can help with that. We have home-based primary care programs. If you're too sick or have problems getting in to see a provider here on our campuses, where you can actually, they come to you, nurse practitioners, dietitians, social workers, psychologists, chaplains, therapy. And then we have medical foster homes for people as an alternative choice to living in assisted living, where private people open their homes that are vetted through the VA, and 2 or 3 veterans live in that home and receive support through the VA. So just to name a few of those things, there's just a lot of services that are available. And like I said, I had to, once I started working at the VA, share them with my grandfather as he's gotten older, to help support him at home like we're able to do. All right, I think my time is up, and I'm so sorry I wasn't able to do the navigation of the website.
That's okay. You've presented some amazing information, and I think it would be very worthy of us doing a part 2 to this. And I love the idea of, bringing the website up. You touched on a lot of various programs. I think something I wanted to touch back on too, Joann, was you referenced one of your family members who was a veteran that didn't dial into services until they were,
Yes.
in their 80s or 90s.
Yes.
I think for anybody that's working with veterans in the community, one of those really important first questions is, did you serve in the military? And then a follow-up question is if it was yes, because sometimes they don't self-identify as a veteran because it wasn't combat service, or it was just 2 years, or I was just a cook. So asking about military service is important. And then if it's a yes, are you using VA healthcare services? And for many reasons, oftentimes veterans choose not to engage in the system. Maybe they have their own private health insurance, or they want to use a community provider. The goal of these briefings is to really highlight just the plethora of support that the VA and community providers have. So I always strongly encourage the eligibility call eligibility and see if you qualify. And even if it's just the annual visit once a year, just so you're in the system, it's a service and a benefit that these veterans through their service have gained the right to access. And I think that's why we're such strong proponents of this community-wide education, is to advocate for tap into the resource if you qualify. We actually worked through one of our coffee connections with a veteran who back in the day had applied and was told no, he didn't meet certain criteria. Situation and circumstance and things had changed with time, and that veteran and his spouse were actually able to be connected into the healthcare system, she's receiving caregiver support services from the VA. So it's never too late to look into it. So my first recommendation is always to call to the VA, check with eligibility. Do I qualify? Can I get some services? And kind of that be the first step. But I would love to do a part two. I think that would be really beneficial just because there is so much that people don't know about.
And if I can just add one more thing, it's always, it can be daunting or scary to start the process. And VHA is a very large system. But just know, yes, going through eligibility to sign up or sign in so that you're in the system should you ever need it in the future. But another way, if you're having an emergency and you're wanting to get into the system, if you have a emergency, if you show up in our emergency room, they do that eligibility evaluation pretty darn quickly with you. Just as a side tip, they won't turn you away because you haven't pre-registered. It's just expedites that process. And I am by no means telling you go through an ER to get registered for the VA. That is not what I'm saying. That is not a recommendation. But in an emergency, if you haven't registered and you really are interested or wanting to seek care from the VA, that is an avenue that they won't turn you away.
Absolutely. And I just put into the chat the main switchboard number for the VA to ask at Bay Pines to ask for the eligibility for those of you who are veterans not using services or working with veterans to advocate for them to explore that. And then the VA website, Joanne, do you know that offhand? So we could put that in the chat.
If you just do va.gov, someone already did that. Yeah, va.gov, and then you can, it says to select which VA. So it's Bay Pines, and it'll get you to our local site. I know we're over time, but the funny thing is our switchboard, when sometimes I get so many calls from the switchboard because they're not sure which way to route a call. And they're like, well, we always know you answer your phone. Like people in the palliative clinics. So I just always think that's funny. So if in doubt, you can ask that type of question, but it can be daunting at first. So always, it helps knowing another veteran or someone that can help you navigate if you're feeling overwhelmed. I don't want that ever to be something to stop people from gaining access.
Absolutely. And we did have a question from one of our attendees about when this recording will be posted onto our website. So after the recording stops today, we do submit that over to marketing. So it'll probably be up online within, by the end of the week, I would presume. So just all of these sessions are recorded, and so there's just a lot of information about VA and community providers. We've been doing this for since the start of 2021, so a lot of really great recorded inventory, as well as today's session will be up there as soon as possible.
Oh, and I'm seeing all the people now. I was on the wrong chat. How many who's here? This is great.
We had about 27 at the top of the call, so some folks have kind of dropped off as time has gone on. But yeah, really good information. Melissa, did we miss any questions? You're on mute.
I don't think so. I was scrolling back and I didn't see anything else, just lots of thank yous. And
one person did say, I'm curious about symptoms. Why do I always hear about the symptoms being different for men and women? I think we missed, did I say that?
You did address it, which is why I didn't ask it. You covered it in that slide. So yeah.
All right.
I think we got them all.
All right. Thank you guys. This was fun.
Well, thanks everyone for joining us, and stay tuned. We do have for March 23rd next month is our annual nod and appreciation event to our Vietnam veterans. We will be having a Zoom session such as this with some guest speakers to thank our Vietnam veterans and welcome them home. In April, we are looking to talk about advanced directives, living wills, which is a very important topic, so put that on your radar. And then I think, Joann, we can discuss offline whether you would like to come back for a part 2. And I think really digging into that website and how to access some of those programs, and just there's been a lot of engagement today on the chat and people asking questions. So I think there's still a lot to uncover and educate people on. So I think part 2 would be great.
Okay, wonderful.
Yeah. Wonderful. Well, thank you so much to everyone for joining us. If you do have any follow-up questions, please do feel free to reach out to me, and I can put you in contact with Joann and answer any questions about services here within Empath Health and then other community providers as well as the VA. And certainly if you have any topics of discussion that you would be interested in learning more about, feel free to share those, because the whole idea is that we're providing information and education that's of use to the community, not just what we think you want to hear. So I very, very much appreciate everybody's attendance. I'm sorry we did run a little over, but you being here today is very appreciated. Thank you so much.
Thank you all.